Hi, my name is Nicole Fox. I'm a PA working in rural family medicine for San Juan Health in Southeast Utah. In our third module, we're going to be talking about the diagnosis of sleep apnea. We've already talked a bit about how obstructive sleep apnea is underdiagnosed, and one of the reasons that this underdiagnosis exists is that patients are often really hesitant to do a sleep test. This is because in the past, we only had attended polysomnography at a verified sleep center. And so patients were really hesitant to leave their home, to be sleeping in a foreign environment, and potentially have somebody watching them throughout the night. With the advent of home sleep studies, I've really found with my patients that their uptake of these tests and their willingness to do the test for diagnosis has really increased. The minimal set of sensors for an adequate home sleep study test includes a nasal cannula to monitor air pressure and airflow, a chest strap to monitor chest rise and fall, and a pulse oximeter so that you can monitor a patient's oxygen and heart rate. Home tests must be provided by an accredited sleep center, and the results must be interpreted by a board-certified sleep professional. It's also important to know that you need at least one night of data, and that data needs to be for at least 4 hours of uninterrupted sleep to be able to get an accurate test result. For certain patients, however, we still do use an attended polysomnography or a sleep study. The reasons that you would still want to go with an in-center sleep study include the results from a home test that were inconclusive, someone who might have some other sleep-related disorders, someone that might have respiratory disorders or other comorbidities, people that have an issue with being able to set up the machine at home or have the technology awareness to be able to use the machine at home, or if they don't feel like they can get a good amount of restful sleep at home that will be uninterrupted for at least that 4 hours. For example, I have a patient with a special needs daughter, and that special needs daughter unfortunately frequently interrupts her during the night. And so for her, an attended sleep study was really crucial to be able to get that data that we needed to move forward for the next step in diagnosis. It's also important to recognize that an in-person sleep center requires the patient to stay overnight at a sleep testing facility. So this requires that the patient can both have transportation to the facility and be willing to stay overnight. When you receive a patient's sleep study results, what do you do with them? The important metrics to look at are the AHI, or apnea-hypopnea index, as well as the time of desaturation below 90%. An apnea is a complete collapse of the airway or a decrease of normal respiration to less than 10% of what you would expect for normal respiratory effort. A hypopnea is a decrease of greater than 30% of normal respiration for at least 10 seconds. And this ratio of the apneas to the hypopneas over the total time sleeping is what you look at to calculate the AHI. The AHI is used to grade the severity of sleep apnea. For mild sleep apnea, you have anywhere from a 5 to a 15. For moderate sleep apnea, the score is between 15 to 30. And if you have an AHI of greater than 30, that indicates severe sleep apnea. Significant oxygen desaturations may indicate that there might be other comorbid diseases present, such as COPD, that might indicate that supplemental oxygen is a very important part of CPAP therapy. The severity of the sleep apnea that's documented in the sleep study then helps us to understand what options we have for treatment for our patients, which we'll go over in our next video.